Hey guys, so today I'm back with another mock USMLE question. This is going to be question number 25. So you have a 65-year-old male, past medical history is notable for HFrEF with an ejection fraction between 20 and 25%, hyperlipidemia, obesity, and CKD, who comes to the ED with acute onset shortness of breath. Patient states that shortness of breath is work with exertion and is associated with concomitant lower extremity swelling. Temperature is 37.2, blood pressure is 156/94, and pulse is 86 beats a minute. Physical examination is notable for an elevated JVD and 2+ lower extremity pitting edema. Laboratory findings remain pending. Chest x-ray is obtained, which I'll show you in a second. What is the most appropriate management for the imaging findings? And so here are the imaging findings. Take a second and pause right here if you need more time to look at the imaging. So once again, the question is asking, given those imaging findings for this patient, what is the most appropriate management of the imaging findings? And the options are thoracentesis, diuresis, IV antibiotics, and pleurodesis. You can go ahead and pause the question if you need more time. And once again, this is the image. The correct answer is going to be diuresis. So let's work our way through this question. So the question stem highlights several different things. One of the key things to note is that the patient's past medical history is notable for HFrEF with a fairly low ejection fraction, and he's coming in with shortness of breath. Whenever you have a patient come with shortness of breath with a history of HFrEF, one of the first things on your differential should be CHF exacerbation. This patient has several other signs of CHF exacerbation, including lower extremity swelling and elevated JVD. So all these things combined, at least as of this moment, the highest thing on your differential should be CHF exacerbation leading to shortness of breath. But the question isn't asking about that. The question is asking about the patient's chest x-ray and what to do about that. So let's look at the chest x-ray. This is the chest x-ray. And in the chest x-ray, just to go through it briefly, there are a couple of things. Whenever you see any chest x-ray, you want to start off with the ABCDE approach. A is you look at the airway. Is the trachea midline? B is you look at the lung fields. Are there any signs of consolidations or effusions? C is you look at the heart. Does the heart appear enlarged? Are there any abnormalities? And then D is you look at the diaphragm. And then E, you look at everything else. For instance, everything else would include the fact that this patient appears to have potentially a pacemaker, and then E, you also look for whether the patient has any fracture. So going through the ABCDE, airway, trachea appears midline and patent. Looking at the lungs, what we see is a right-sided pleural effusion because we're unable to see the claustrophrenic angle. C, potentially look at the heart. We could say there's cardiomegaly, but it's hard to say given that the heart borders are obstructed, secondary to pleural effusion. And then E, everything else, we do see essentially, once again, external cardiac pacemaker. So the most important thing I wanted to highlight, once again, with regards to this image is it's very important to be able to identify pleural effusion. That's what it looks like when a patient has a right-sided pleural effusion where you're essentially unable to see the claustrophrenic angle. But the question isn't simply asking what the imaging findings are. The question is asking, given these imaging findings, what is the most appropriate management? One of the key things that you should remember is that when patients have a pleural effusion, typically what you have to do is a thoracentesis, which allows you to distinguish whether a pleural effusion is transudative versus exudative. However, if a patient has a pleural effusion in the setting of CHF, you do not have to do a thoracentesis. In that case, you can just treat the underlying CHF exacerbation, which you normally treat with diuretics, and the pleural effusion for the vast majority of patients will go away typically in 48 hours. So once again, for patients with pleural effusion in the setting of CHF exacerbation, you can just treat that with diuretics. However, patients who don't have a history of CHF and aren't being treated for CHF exacerbation, if those patients have a pleural effusion, in that situation, you have to do a thoracentesis with labs to figure out whether that pleural effusion is transudative versus exudative. And it's also very high yield to remember that the way you distinguish a transidative versus exudative pleural effusion is using the Leitz criteria, which I'll go through in a second. The last thing I just want to briefly mention with regards to this question is option D, pleurodesis. That typically is only used when patient has essentially pleural effusion in the setting of malignancy, where patients are having repeated pleural effusion, and you essentially have to stick the two layers of pleura together to prevent additional episodes of pleural effusion. So now next, let's just go through the Leitz criteria. And once again, Leitz criteria is incredibly important to know as a medical student. You will be pimped ad nauseum on this. So the Leitz criteria, once again, as mentioned, helps you distinguish between transidative versus exudative pleural effusion. And in order to decide whether something is transidative versus exudative, there's a couple things you need. You need to know what the LDH values are in the serum and pleural fluid, and then you also need to know what the protein values are in the serum and pleural fluid. Now, if the pleural fluid protein divided by serum protein ratio is less than 5, that's more consistent with a transidative. If the LDH ratio for the pleural fluid divided by serum fluid is less than 0.6, that's considered more consistent with a transidative effusion. And if the pleural fluid LDH is less than 2/3 the upper limit of normal, that's more consistent with the transidative pleural effusion. If for any of these three categories, if the criteria for exudative effusion is met, then that effusion is more consistent with the exudative effusion. And just to briefly go through it, it's important to be aware of the differential. The key things, the two really high yield ones that come up repeatedly for transidative include things like CHF and nephrotic syndrome. And remember, in transidative pleural effusions, the capillary membrane is intact. There's either increased hydrostatic pressure that we see in CHF exacerbation, which leads to pleural effusion, or there's decrease in oncotic pressure, which can happen, for instance, in patients with nephrotic syndrome because they're losing a lot of protein. As a result, there's pleural effusion. So remember, once again, transidative, the capillary membrane is intact. In exudative, typically there's some sort of damage to the capillary membrane, which leads to additional leakage of not just fluid, but additional cells. And that's why it tends to be higher in protein and LDH. And exudative includes things like perineumotic effusions, empyema, and malignancy. And so, once again, just to bring everything together, remember, if you have a pleural effusion that's in the setting of CHF exacerbation, you don't have to do a thoracentesis, just treat with diuretics. But if it's not in the setting of CHF exacerbation, typically in that situation, you do have to do a thoracentesis to figure out whether it's transidative and exudative, and also to help the patient clinically. So that's going to be it for today. If anyone has any questions, feel free to put a comment down below.